It's a pleasure to be with you. Unique aspects of managing chronic hepatitis B are listed here. First, in contrast to, for example, chronic hepatitis C, hepatitis B is not curable at the present time, but controllable. Hepatitis B surface antigen loss, so-called functional cure, is our best serological marker of immune control and is associated with the lowest risk of complications. And so while it's highly desired, it actually is infrequently achieved with current treatments. And this is influencing then our selective use of current treatments. Hepatitis B is also very dynamic, with phases of the infection that are active, which warrant treatment, and those that are inactive, where we choose not to treat. So we're targeting those with active disease, defined by, as you'll see, ALT and HBV DNA levels. Because of this very dynamic nature, where it changes over the course of the lifetime of infection, this requires monitoring on an ongoing basis to determine the timing of interventions. So our current paradigm for treatment of chronic hepatitis B is to treat those that are at risk for disease progression. And those are the patients that have active chronic hepatitis B, active defined, again, by ALT and HBV DNA level, and I'll review the specific thresholds. We also target those that have cirrhosis, since this is the group that is at highest risk for immediate complications. So as shown on the left, the groups recommended for treatment now include those with active hepatitis B E antigen positive and negative chronic hepatitis B, those with advanced fibrosis cirrhosis, those with co-infection for HIV because they are at risk of accelerated disease, and then we have some special populations to consider, such as those that are on immunosuppression and those with pregnancy and high viral loads. Importantly, there are key groups that we defer treatment in or recommend not to treat, and that's inactive chronic hepatitis B and those with immune tolerant or chronic hepatitis B infection. So as emphasized, there are three criteria used to determine the need for treatment: ALT, HBV DNA, and liver disease severity. And we apply this in both E antigen positive and E antigen negative patients. You can see that across the guidance documents, AASLD, EASL, and APASL, that there's a lot of similarities in terms of the thresholds that are used to make this determination. For E antigen positive patients, that number is greater than 20,000, and for E antigen negative, greater than 2,000 across most of the guidance documents. You can see there's some variability in terms of the ALT threshold, whether it's the upper limits of normal, but most use greater than 2 times upper limit of normal. And all recommend treatment in those with cirrhosis or more advanced stages of disease. And then other factors that come into play are family history of liver cancer or cirrhosis, extrahepatic manifestations, and to some degree, older age. Now, I'd emphasize that the HBV DNA and ALT thresholds that are provided in guidance documents are meant to be just that, a guide. They're not absolute. So if your viral load happens to be 1,800 instead of 2,000, that shouldn't influence strongly your decision about whether the patient meets the criteria. It's meant to guide you in terms of what's the approximate level I should be thinking about in terms of what's relevant in defining active disease. In all cases, and I'll come back to this, you should always confirm that the ALT elevation is due to HBV and not due to other things, and that's particularly the case these days since fatty liver is very, very prevalent. Just one slide to emphasize that all patients with cirrhosis should be treated. This is a very nice study that looked at untreated patients who had cirrhosis and then characterized them by HBV DNA levels and ALT levels. And you can see that even though all of these patients had an HBV DNA level that would be classified as low, under 2,000 IUs per ml, that the group that had the very lowest risk for hepatocellular carcinoma was the patients that had an undetectable HBV DNA level in conjunction with a normal ALT. And for this reason, many of the guidance documents now recommend that all patients with cirrhosis should be treated, and that's to ensure that they always have an undetectable HBV DNA so that we can minimize the risk for subsequent complications like liver cancer. So just in very broad strokes, the way we approach treatment currently in the absence of a curative alternative is, on the left is the treat now group, which is characterized by that active disease, elevated HBV DNA and ALT levels, or patients with significant or advanced fibrosis. And then on the far right is the group that we don't treat, those that are not at risk for cirrhosis, liver failure, and liver cancer, those that have inactive chronic hepatitis B, and those that are immune tolerant. But I want to emphasize that there's a large number of patients that don't neatly fit into either the green or the red box. Those patients so-called in the gray zone, where their ALT or HBV DNA levels may be more indeterminate. And how common is that finding? Well, shown here is a study from California and Taiwan of 3,666 patients, all of them untreated without cirrhosis at entry. And you can see that in terms of using the ALT level of 2,000 for e antigen negative patients and 20,000 for e antigen positive, and ALT levels greater than 2 times upper limit of normal, that they still had nearly 40% of patients who couldn't be defined as either being active or inactive, and were in this indeterminate phase. And when they followed those patients out to 5 years, nearly 3/4 of them still remained indeterminate. So what do you do with these gray zone patients? Well, regardless of whether they're e antigen positive or e antigen negative, whenever you see an elevated ALT, you should ask yourself, is it due to the hepatitis B, or could there be something else that's causing the elevated ALT and accounting for that, like alcohol or metabolic fatty liver disease? The second thing is, of course, to assess for whether they might have underlying significant fibrosis or inflammation that would push you towards considering treatment regardless of the ALT level and HBV DNA. And then the other is just to follow them longitudinally to get a sense of the trajectory. So in e antigen positive patients, what you're looking for is, in the immune tolerant patients whose HBV DNA level starts to decline, that can often be an indication that they're transitioning to immune active chronic hepatitis B. And in the case of e antigen negative patients, generally HBV DNA is the best marker of what the likely evolution of that e antigen negative patient is, with those that have higher HBV DNA levels more likely to transition to more active disease. And then take into consideration age, both for e antigen positive as well as e antigen negative, recognizing that older age is also a factor that is influencing the decision to treat. Now, in terms of what do we treat with, we have peg interferon, and we also have nucleoside analogues as a class. And I'm going to not spend too much time on this slide, but to make the point that the vast majority of patients receive a nucleoside analog. And the reason for that is that they're very well tolerated. They can be used in all stages of disease, and they're orally administered. And so that's highly attractive to patients and to providers. But it does typically require long-term or indefinite treatment, as we'll discuss. And because of that, peg interferon may have a role. It's finite. So it might be attractive to some patients that are able to tolerate it. And it is recognized that it does result in higher rates of S antigen loss, so that may be particularly attractive as we move towards seeking functional cure. Now, in terms of using the two classes of drugs together, peg interferon plus a nucleoside analog, generally that's not a recommended strategy, as it's not been shown to really be particularly additive in terms of benefits to patients, but there is renewed interest in using these drugs as a switch or add-on therapy. So just to make the point, nukes are safe. Look at the list of patients that can take these drugs very safely, highlighting how well tolerated they are. Everyone from decompensated cirrhotics through to those with co-infections, children, adolescents, and even pregnant women. So how do you choose among the preferred NA therapies for chronic hepatitis B? What's recommended by all the guidance is that the preferred drugs are entecavir, tenofovir AF or alafenamide TAF, or tenofovir DF. All of them offer you high antiviral efficacy with low risk for resistance. But there are scenarios in which one or two of the drugs may be preferred over the other. So for patients that are older, have bone disease or renal abnormalities, you want to avoid TDF, so TAF and entecavir are preferred. For those with HIV, prior lamivudine exposure, you'd want to avoid entecavir, so TAF or TDF is indicated there, and in pregnancy, TDF is recommended since it's the best studied. There's been recent data that have suggested there may be a differential effect of nucleotide analogues like TDF versus nucleoside analogues such as entecavir. And the first study to raise the possibility that there may be a differential effect on outcomes, and in this case, HCC, was a study published in 2018. It's shown on the left. This was based on a Korean National Health Insurance database. And you can see in this propensity score matched nationwide cohort that when they looked at the probability of HCC, they saw that it was higher in entecavir treated patients compared to those on tenofovir. Now, this generated many other studies, and shown on the right is a propensity matched cohort looking at the endpoint of HCC, and again, comparing entecavir to TDF. And it confirms the finding in that there's a 25% lower likelihood of HCC in patients on tenofovir DF compared to those on entecavir. But this still remains very controversial as to whether there is a differential effect in NAs by HCC risk, and the most recent expert commentary on this suggests that there's still insufficient data to recommend a switch from entecavir to TDF, and certainly doesn't seem to be sufficient data to warrant a decision about which one you might start with. But keep in mind that this is an evolving area and an important one where we try to understand some of the other maybe unique benefits of one of our preferred drug over another. So the last area I'm going to cover in my talk is, okay, you've identified the patient who should be treated, you've picked your preferred therapy, and the question is, can you and when should you stop the treatment? So here are the recommendations for e-antigen positive patients where indeed guidance documents suggest we can stop treatment in patients on nukes. And AASLD, EASL, and APOSL all are quite consistent in saying that we should treat until we get e-antigen seroconversion with undetectable HBV DNA and normal ALT, and then do some period of consolidation therapy. And that at a minimum should be 1 year. And APOSL suggests that it should be ideally 3 years or more. And I would say the APOSL guidance is well supported by data that shows that longer consolidation is associated with a lower risk of clinical and virological relapse. So shown on the left is on the top graphic is the effect of relapse by age, and on the bottom is the effect of consolidation therapy. And you can see that those that are younger and those that had longer duration of consolidation therapy had the lowest rate of clinical relapse. And that's shown in a second study on the right where they combine these two effects. And you can see again here that the lowest rate of virological recurrence, in this case being the outcome, was in those that were less than 40 years of age and had greater than 15 months of consolidation. What's the overall rate long-term of seeing a clinical relapse in patients who stop nukes who are e-antigen positive at the start of treatment? This is nicely shown in this study and confirmed by others, that overall the cumulative rate of virological clinical relapse is about 50%. So that indicates that about half of the patients will end up having to resume treatment at some point. But note that there is a fairly high rate of S antigen loss over time as well, in this case 20% over 8 years. And when we've looked across studies in general, as I said, the quoted rate of clinical relapse with longer term follow-up is about 50%. And there are factors that have been associated with a higher likelihood of sustained response, and I've highlighted some of them for you. Being younger at the age of seroconversions, one, longer duration of consolidation therapy. So indeed, the APOSL recommendation to have consolidation duration of 3 years or more may be appropriate. Undetectable as opposed to less than 20 IUs per ml of HBV DNA at the end of treatment is another factor. And here too, but rather in this case, entecavir being the drug that results in more sustained responses. So again, showing that there may be a differential by type of nucleoside analog. And turning now to the e-antigen negative chronic hepatitis B patient, can we stop NA therapy here? The answer is yes, but not often. ASLD actually recommends treating indefinitely or until S antigen loss. EASL and APOSL also have a recommendation to treat until S antigen loss, but leave open the possibility of stopping earlier. EASL indicates you can treat for at least 3 years with undetectable HBV DNA for at least 18 months before stopping. And APOSL says to treat for at least 2 years with an undetectable HBV DNA for at least 18 months. In general, across the guidance documents, they recommend against stopping in individual cirrhosis due to the risk of decompensation if the patient were to flare post discontinuation of treatment. And while all of the guidance documents say that you can treat until you get surface antigen loss, you can see that the rate of S antigen loss is extremely low. And then that means generally indefinite therapy or moving towards these more truncated periods of treatment. So what's the typical course when you withdraw nucleoside analogues in e-antigen-negative chronic hepatitis B? Well, this is very nicely shown in this cartoon. Typically, when you stop treatment after a treatment phase of 3 years or more, you'll get a somewhat of a lag period where there's still low HBV DNA and normal ALT levels. And then you'll have a reactivation phase in a proportion of patients. This reactivation phase can result in severe flares in some patients, which is why these patients require very close monitoring. The reactivation phase can last many months, but ultimately it moves into a consolidation phase where you can see what the outcome of the withdrawal will be. And the beneficial outcomes would be that you either get S antigen loss or you get a sustained inactive chronic hepatitis B status. But there could, of course, be a proportion of patients that are going to need retreatment or that fall into that indeterminate phase and require close monitoring. When we look at the many studies that have been done, with nucleoside analog withdrawal in e-antigen-negative chronic hepatitis B, as shown in this table, there's very few prospective studies. And you can see some of them are very small in numbers, others quite large, and that the nucleoside analogues used is highly heterogeneous. Overall, there's a wide range of reported rates of S antigen loss, but on average, about 20% will achieve S antigen loss with 3 to 5 years of follow-up. And importantly, half to nearly 3/4 have inactive or minimally active disease and can remain off treatment. So that suggests that indeed a significant proportion of patients who are e-antigen negative can be discontinued from treatment and remain off treatment. The question is, can we identify the patients that are likely to do well? And here's just one example of how we might think about factors that influence the risk for clinical relapse. And this is a very nice way of, I think, putting together several different factors. You can see in this study that looked at quantitative S antigen, the duration of treatment, and the duration of consolidation, in this case, the period during which the HBV DNA was undetectable. You can see that the lowest rate of clinical relapse was in the patients who, when they stopped treatment, had a quantitative surface antigen under 1,000, had had at least 3 years of treatment, and a consolidation phase where they were undetectable for at least 2.25 years. And that was substantially lower in patients that didn't meet those clinical criteria. So what's the bottom line in terms of stopping NA treatment in e-antigen negative chronic hepatitis B? Well, it's not recommended in patients with cirrhosis. And if you decide to stop, you want to ensure that you've had a prolonged period of HBV DNA undetectability and ALT normalization prior to stopping. Typically 3 years might be the right number. Be prepared to monitor the patients closely, at least for the first 6 months, and have a strategy to manage the HBV flares. Many will require, not many, but a proportion will require restarting treatment. Severe flares can occur, albeit infrequently, but patients need to be informed of the potential risk. And lower quantitative surface antigen is the best predictor of good outcomes in terms of both a low risk for clinical relapse and high rate of S antigen loss. What the exact threshold is that is the best predictor is not known. It's clearly outcomes are excellent if the surface antigen quant is under 100, but higher levels may also be safe. So just my final points. Again, HBV is controlled, not cured, so you need a long-term treatment strategy. Nucleoside analogues have proven to be a safe and highly effective form of viral suppression, have gained us a lot of very important clinical benefits. I didn't speak much about PEG interferon. It has a more limited role, but I'm going to acknowledge that maybe it's having a bit of a resurgence in the context of trying to achieve surface antigen loss. But until we have curative therapies, our treatment targets are those that are at risk for liver complications. So we do focus on immune active phases and those with significant fibrosis. But keep in mind that many patients fall into the gray zone, and these are more challenging sometimes to make a decision about, should I treat, should I not? But follow the patient, take into consideration trajectories of HBV, DNA, and ALT, and the patient's age, and monitor, monitor, monitor. The current treatment endpoints focus on e-antigen seroconversion and sustained clinical remission, but as you know, we are shifting in our thinking about treatment towards functional cure. Discontinuation of therapy can be considered in select patients, but it requires a careful weighing of risks and benefits of the health outcomes, and you need to have a motivated patient and provider who can do the close monitoring when treatment is discontinued. And with that, I'll close. Thank you very much for your attention.
The question is management of hepatitis B in cirrhotic liver having hepatitis C as well. Hello.
Can you hear me?
Yes, we can.
Okay, great. Okay, I'm seeing the questions come up in the chat, so I didn't hear them before. So maybe I'll just take a few of the questions that I'm seeing in the chat. The first is hepatitis B surface antigen positive. HBV DNA in the blood is negative, but F4 fibrosis, so cirrhosis. All other cause of liver disease ruled out. As HBV DNA may still be present in the liver and tissue, should a liver biopsy be done in the liver of treated patients without or not? Well, these patients on nukes. And I have to say that I think that the answer is no, that we're really moving away from doing biopsies truthfully to make treatment decisions. And this kind of patient in my clinic, HBV DNA negative, but surface antigen positive with cirrhosis would be on a nuke, and I would leave that patient on a nuke indefinitely. And so I wouldn't be influenced by the presence of HBV DNA in the liver on a biopsy. I'd really be using the surface antigen as my marker. But I have to acknowledge that really there may be other markers that might be useful in this setting, like the Hep B core-related antigen, others that might help us to be making decisions in the future on when we might be able to stop nukes, even in our patients who may have cirrhosis. But I think at the moment, the idea is that a cirrhotic patient, we're really trying to minimize any chance that that patient would have any ongoing viral replication in the liver or measured in the serum that might ultimately lead to either progression of their liver disease, to decompensation, or perhaps influence their risk for liver cancer. So the strategy is you would still put them on suppressive therapy as long as they remain surface antigen positive in the blood. So that's the first question. The other is, how do you manage hepatitis B cirrhotic patients with HCV? Well, it's become easier, certainly, since we have DAAs available. So again, you have to, and I'm going to acknowledge that sort of this is where I think the AASLD and EASL guidelines differ from APASL, where APASL sort of gives this option of having somebody with cirrhosis not on nukes. Both EASL and AASLD recommend nukes for indefinitely in patients who are cirrhotic. So again, if this is a Hep B patient and they have cirrhosis and then they also happen to have Hep C, I would have them on a nuke for their hepatitis B, and then I would give them a course of DAA therapy for their hepatitis C to manage that infection. The nice thing about C is that's a finite course. In contrast, hepatitis B right now is still indefinite therapy for the patient with cirrhosis. There's another question about quantitative surface antigen helping. Oh, that's a great question, actually. So thanks for that question. It's regarding this gray zone patient. And I highlighted it in my talk because I think it is important that we acknowledge these patients whose levels are just not quite at the level where we consider treatment, but they're still not low enough to make us comfortable that they're truly inactive. I think that's the challenge. So the question is, can we use surface antigen quant to maybe help us, both in starting the patient who's borderline and then maybe also for stopping? I think more of the data here is on stopping. So, and especially in e antigen negative patients, although there is some in the patients who start out e antigen positive as well, but certainly quant surface antigen is probably the most studied in terms of a predictor of stopping treatment. And lower is better. Certainly values under 100 and 150 seem to be very safe in terms of, stopping very low rates for clinical relapse. But there are other studies that show 500 might be a good number. So I'm not sure we know exactly what it is, but lower is better. But I don't think it's as well studied how to use the surface antigen quant in the gray zone patients to make a decision to start treatment. So I think that's a great idea. And I think that would be something that should potentially be looked at as whether it can help in those gray zone patients to decide, should you pull the trigger to treat? But where it might be helpful is, again, inactive hepatitis B, or the people that look like they're more inactive, tend to have lower surface antigen. So maybe I'd be more reassured in a patient who's indeterminate and who has a low quant surface antigen. And then the last question is there any data on TAF in pregnant women to prevent mother-to-child transmission? And the answer is yes. There's some modest-sized studies. I think they've been published, actually, since I do recall I've seen them. And I think there are being at least 1 or 2 that are being presented at the upcoming meeting, I believe. So we're seeing other studies come out. So there's an accumulating data around TAF. And my suspicion is that it's going to prove to be safe as well. But at the moment, if people ask me what drug to choose to use in pregnancy, I would still say TDF is one where we have the most data, both from HIV, HBV, HIV and HB infected mothers. There's so much data about its safety. So I would still use it, but I guess if you have a woman who's already on TAF and then becomes pregnant, I think you can be somewhat reassured that the data that's emerging suggests that TAF is also safe.
Thank you so much.
My pleasure. Always wonderful to be participating. Thank you.
Thank you so much. So that's Dr. Nora giving her message. Hepatitis B is controlled but not cured. Long-term treatment plan is needed. Thank you so much. Our next speaker will talk on national and international consensus regarding hepatitis B treatment, duration, and follow-up. He is International Faculty of Pakistan Society of Hepatology, Professor Dr. Rafael Esteban. He is holding MD degree, is head of internal medicine and liver unit of Hospital Universitario Vall d'Hebron in Barcelona, Spain. He is also professor of medicine at Universidad Autónoma de Barcelona. He is member of American Association for Study of Liver Diseases. He had been member of Scientific Committee of European Association of Study of Liver Disease and Secretary of Spanish Association for the Study of Liver Disease. Professor Dr. Rafael Esteban.
Hello, my friends. It's my pleasure to give my presentation today. Unfortunately, I cannot be in Lahore, but anyway, I think and I hope that next year will be presentially in the meeting. Thank you for the invitation.
És aviat la presentació.
Can we go to the presentation, please?
The recording.
Dr. Rafael, you have to, would you present yourself? Can you share your screen?
Can you share your screen?
This is a recording presentation. Dear friends, it's my pleasure to participate in your meeting. Unfortunately, I cannot be present, but anyway, by streaming, I will try to do the best to do the task about treatment of chronic hepatitis B, a look at the different recommendations by the scientific societies. These are my disclosures. And you can observe that there are three main scientific societies, the EASL, so the European Association, the American Association, and the APASL. The guidelines are fairly similar in their recommendations. The endpoints of therapy are clear. The first one is induction of long-term suppression of HBV DNA. This is the main endpoint of all current treatment strategies. The second is induction of e-antigen loss with or without anti-HBe seroconversion in E-positive chronic hepatitis B patients. This is an important endpoint, often representing partial immune control of the chronic HBV infection. Biochemical response means ALT normalization is an additional endpoint achieved in most patients with long-term suppression of HBV replication. Finally, HBsAg loss with or without anti-HBs seroconversion is an optimal endpoint indicating profound suppression of HBV replication and viral protein expression. Here you have the endpoints, the goals in the treatment of chronic hepatitis B. In fact, virological and biochemical reversion is feasible practically in all compliant patients. But the negativization of HBsAg and HBV eradication is an ideal but not realistic endpoint with the drugs which are available right now. With treatment of chronic hepatitis B, we try to prevent liver cirrhosis, improvement of survival, and of course, prevention of liver cancer. About treatment duration, there is very clear. With PEC interferon, the duration should be 48 weeks. All the societies agree on that. With nucleoside analogues for those e-antigen positive patients, again, there is an agreement until e-antigen seroconversion plus a consolidation period of 9 versus 12 months of therapy. For those E-negative chronic hepatitis B patients, the situation is different. The EASL and the American Association recommend treatment until HBsAg loss, which means treatment forever in the majority of patients. The APASL differs and recommends 2 years of treatment for those patients being HBV DNA negative during this period of time. What about the discontinuation of treatment? Here you have the efficacy of 48 weeks of PEC interferon, end of therapy, and sustained off therapy responses. And you can observe that after 6 months of follow-up, roughly 30% of patients present e-antigen to anti-E seroconversion. And those E antigen negative patients, the rate of response is even less. Only 19% of patients after 6 months of follow-up achieve the sustained response. There are some rules, very interesting rules, to shorten therapy for those patients who do not respond to therapy. When we are using interferon at week 12 for those E-positive patients, if there is no decline of the HBsAg, you can stop therapy for genotype A or D. For those genotype B or C, you need to have a decline of over 20,000 international units. For those E-negative patients, again, at week 12, if there is any decline, you can continue. If there is no decline, you can stop therapy at that time. So when to stop therapy with a nucleoside analog? Stop therapy after HBsAg loss. This is very clear. There is the functional cure and all the societies agree on that. What about to stop nucleoside without HBsAg loss? International guidelines for stopping before HBsAg loss in E-positive patients, they decide that nucleoside can be stopped after E antigen to anti-E seroconversion and with an undetectable HBV DNA 6 to 12 month consolidation. Here you have the rates of durable E seroconversion after nucleoside discontinuation. There's a systematic review of 6 studies, and you can observe that at 6, 12, or 24 months after discontinuation, there is a very high rate of durable E seroconversion. Roughly after 24 months, 88% of patients present a sustained seroconversion. What about the rates of virological remission after nucleoside discontinuation? Again, this is an analysis of 14 studies, including more than 700 E-positive patients, and you can observe that roughly 50% of patients present with sustainable HBV DNA less than 20,000 international units. For those E-negative patients, the situation is different. So only 30% of patients after 48 months of discontinuation present a remission, and only 1.7% present a negativization of HBsAg. So again, the guidelines differ in stopping nucleosides before HBsAg loss in E-negative patients. The American Association recommends no discontinuation before HBsAg loss. The APASL consider discontinuation in non-serotics after 2 years of HBV DNA undetectable on 3 occasions 6 months apart. And the EASL may consider discontinuation in non-serotics after 3 years of on-therapy virological remission and compliance to close follow-up. Here you have, with different definitions, the virological remission among patients after 12 months of discontinuation in E-negative patients. And you can observe that if you include the definition of less than 20,000 international units of HBV-DNA, roughly 50% of patients present this remission, while the duration of non-nucleoside analogues is roughly 75% at 12 months after discontinuation. This compares the incidence of seroclearance of HBsAg in e-antigen negative patients compared to the cohort of the REVEAL study. And you can observe that there is an increase of seroclearance in those patients who stop the nucleoside analog treatment. And there are two factors related to the seroclearance. The first is the quantification of HBsAg at entry, and second, the finite nucleoside treatment. This is the cumulative HBsAg loss rates after stopping nucleosides in E-negative patients, different studies, and you can observe that at the end, over 50% of patients may present a HBsAg loss after stopping therapy on the follow-up. Again, these are the factors related to the seroclearance of HBsAg, and the main factor is the HBsAg at month 0, being 100 international units or less. This proved a sensitivity of 58% and a specificity of 93% for subsequent HBsAg loss. What about the safety of nucleoside discontinuation in those non-serotic patients? So virological relapse is high, between 50 and 90%. The biochemical relapse is between 35 and 50%. But severe HBV reactivation is lower, and liver decompensation is 0. So it's safe to stop therapy in those patients, E-negative patients, after 2 or 3 years of being HBV DNA negative. Very important, those patients should be monitored when treated with any of the nucleoside analogues. All patients should be followed with periodical assessments, including ALT, every 3-4 months during the first year, and then every 6 months, and serum HBV DNA, again, every 6 to 12 months. Patients at risk of renal disease treated with any nucleoside analog should undergo periodical renal monitoring with GFR, and all patients, regardless of renal risk, treated with tenofovir should undergo periodical renal monitoring with at least eGFR and serum phosphate levels. Patients on tenofovir at risk of development or with underlying bone disease should be considered for switch to entecavir or TAF, depending on previous lamivudine exposure. Patients under effective long-term therapy should remain under surveillance for HCC. This is very important. Even those with HBV DNA may develop liver cancer. HCC surveillance is absolutely mandatory for all patients with cirrhosis, as well as those with moderate or high HCC risk scores at the onset of nucleoside therapy. So thank you very much. I think I has covered my task today. Thank you very much. Can I have the questions right now?
We thank you so much, Dr. Rafael. Kindly stay with us. We would want to take questions at the end of this session. Now we are going to the next talk, that is on chronic hepatitis B, its prevalence and management, where we stand today. Our eminent speaker for this talk is Professor Dr. Shahab Abid. He is Professor of Gastroenterology and Medicine Department at Aga Khan University Hospital, Karachi. He had been trained at Aga Khan University in Medicine and Gastroenterology Department. He has research interest at gastrointestinal motility disorder and pathophysiology and treatment of Helicobacter pylori. Professor Dr. Shahab Abid, HBV prevalence and management, where we stand today.
Assalamu alaikum. Thank you very much for a very kind invitation to participate in Pakistan Society of Hepatology annual meeting 2021. Let's share the screen. So the topic of my presentation is HDV prevalence and management, where we stand today. There is no conflict of interest to declare. Hepatitis delta was first described in Italy by Rosito and his colleagues while working with a cohort of patients who were suffering from hepatitis B infection in mid-70s. HDV is a small RNA virus which is require hepatitis B virus for its survival and entry into the hepatocyte. As you can see in this schematic diagram, that the hepatitis delta RNA is having a two kind of small and the large HD antigen, and is surrounded by the small, medium, and large size hepatitis B surface antigen. It's up to 60 million people are thought to be infected at one point in time with hepatitis delta variant infection, but this ranges from 12 million to 60 million. Since its identification in mid-70s, hepatitis delta virus is always a diagnostic and management challenge. Today's presentation outline include hepatitis delta prevalence, natural history, and the management of hepatitis delta variant infection. So for the prevalence of hepatitis delta virus infection, the one of the latest article which is published in Journal of Hepatology 2020, they incorporated 2,104. They considered these 2,000 plus studies on their search terms using PubMed, Embase, and Scopus. And from there, they shortlisted 745 plus 5 studies which were reviewed in full length. And then they have included 282 which were selected for inclusion in the analysis. And these are the results. And this result shows the spectrum of distribution of HDV viral infection in general population and in hepatology clinic. The color coding here, green indicates less than 1% and red indicates more than 50% of the selected population is affected with HDV viral infection. You can see that the color are more intense in those who are attending the hepatology clinics compared to general population. But you can also appreciate that the data is missing fairly large number of countries as far as the general population is concerned. Likewise, the prevalence of HDV in hepatitis B positive patient was also assessed. The diameter of the circle indicates the sample size, while the colors depicts the prevalence rate in various population and in various countries. And here is the hepatology clinic population, and this is the general population. So on the basis of this, they have concluded that HDV is common among hepatitis B surface antigen positive patients. Among hepatitis B surface antigen, HDV prevalence is 4.5%. And HDV amongst surface antigen positive who are attendees of clinics having 16.4%. HDV prevalence is higher in IV drug abusers, HCV and HIV concomitant infections. And HDV causes 18% cirrhosis and 20% of hepatocellular carcinoma. They have further evaluated their data and tried to find out the differences in the odds of developing or having HDV infection while considering various special population. One is the drug abusers, sex workers, homosexuals, patients on hemodialysis, patients who are suffering with HIV and HCV infection, and those who have cirrhosis and hepatocellular carcinoma. You can see here that the odds ratio 19% in the various subcategories of population. So they have also extended their data to see the genotype. The actual implication of the determination of genotype in the clinical outcome is not fully established, but you can see here that there are 8 different kinds of the genotypes associated with HDV infection, and the predominant genotype is basically, which is represented in gray, which is genotype 1. As I said, that the clinical implication is not yet established fully, but it is being said that the natural history of HDV is more recently identified genotype 5 and 8 from Africa and less characterized. A study from Taiwan showed a lower rate of remission and more adverse outcome in patients with genotype 1 than those who are suffering with genotype 2. So there is further studies are required.
Since we're having connections with the audiovisual team, the session can still be viewed on the conference webpage, psh2021.com. You can log on to it. The visuals there, the slideshow is, the presentation is running there just fine. It's just the problem is over here. So until we sort it out, you can keep listening to the talk and you can see the slides on your mobile phones.
Significant
2021.com.
and implication of knowing the genotype for tackling this disease, which is defective to most of the available treatment right now. In Pakistan, one study has been done around 15 years ago when we have collected a data of more than 10,000 lab samples all over the country and from the outlets of AKU laboratory, which is widespread throughout the country. And we found that in hepatitis B surface antigen positive individual, this particular belt, which comprises of Upper Sindh, Lower Punjab, and some areas of the Balochistan, that this is the area where there is a high prevalence of hepatitis delta viral infection, as high as up to on an average 16.6%. So the natural history of the hepatitis delta virus, this hepatitis delta is present in the 2 forms. One is the co-infection, and another is a super-infection, acute and chronic. So in co-infection, which is basically an acute hepatitis delta along with the acute hepatitis B infection, it is short-lived. And there is an elevation of the HBV DNA level along with the HDV RNA levels. There is an elevation of the liver enzymes, and they are all settled down within few weeks' time. In superinfection with acute HDV infection, there is persistent hepatitis B antigenemia. There is elevation of the liver enzyme, which then settle down. There is the presence of HDV RNA, which then settle down. And HBV DNA is on a very low level. While in chronic HDV infection, there is persistent hepatitis D RNA level in the blood. There is persistent antigenemia of hepatitis B, which is required for the survival of HDV. And there is elevation of the liver enzymes, ALT. So if we expand this further, one can say that the patient with chronic hepatitis B, acute HDV infection, which is superinfection, 90% become chronic and develop cirrhosis and hepatocellular carcinoma. And 10% will have a spontaneous recovery. Those who develop co-infection, it is short-lived, 90% have a spontaneous recovery and 5% may develop severe hepatitis. And one subset will convert into cirrhosis and hepatocellular carcinoma. The other will develop fulminant hepatitis failure. So this is when we have a co-infection, healthy individual, 3 to 4%, fulminant hepatitis may result in death, 90% spontaneous recovery. And it's rare to have chronic hepatitis and development of cirrhosis. So the key thing is that they are healthy individuals developing both infections together. Hepatitis B carrier is the main chunk of patients who develop superinfection, which persists there, and which may result in cirrhosis in 80-90% of individuals, and the consequences of chronic liver disease like advanced cirrhosis and hepatoma. What are the investigation and the treatment? How we'll manage hepatitis delta viral infection? So in an endemic area, perform hepatitis B surface antigen, we will have two kinds of the results. Those who have hepatitis B core antibodies, total positive with core IgM negative, they are thought to be chronic hepatitis B infection. And those who develop, who have hepatitis core total and core IgM positive, they have acute hepatitis B infection. As you know that with acute infection, if we perform hepatitis delta antibodies, if total and IgM both are present, it is co-infection. And those who have with the setting of chronic hepatitis B, if there is both antibodies for delta is present, it is superinfection. So once we establish that they have delta infection, one has to perform HDV RNA. And if the HDV RNA is negative, repeat this test in order to establish whether it is actually absent or it is in a small amount, and in the subsequent test it may be positive. But those who have HDV RNA positive, one can go for quantitative estimation and perhaps with the genotyping of this subset of patients. And then the treatment, surface antigen positive, anti-HDV IgG antibodies should be performed in this patient. If they are negative, treat for local HBV as per local HBV guideline. And those who have HDV antibodies are present, perform the HDV RNA. If HDV RNA is negative, perform more than one time, repeat it more than one time, and if it is negative, treat as HBV according to guidelines. But if the HDV RNA is present, perform the liver biopsy. And if you are reluctant for liver biopsy, now one can assess the liver stiffness and fibrosis by doing a fibrosis scan. So that can be done. And then these patients should be offered the only available off-label treatment, which is PEG interferon alpha for at least 48 weeks. And during this 48 weeks time, if you found that HBV DNA level is more than 2000 international unit, consider addition of any potent nucleotide or nucleosides. And those who are found to have HCV RNA positive, add ribavirin. And now one can add the directly acting antiviral agents in order to treat hepatitis C viral infection. So we can debate this area and concomitant high level of HBV DNA in subsequent discussion. But once we have clear to a large extent hepatitis delta by using PEG interferon, and there is reactivation of HBV, then one can think of giving nucleotide and nucleoside in order to suppress the HBV DNA viral replication. So what are the endpoints for hepatitis delta treatment? The best endpoint, which is ideal, is the clearance of hepatitis B surface antigen loss and anti-hepatitis B seroconversion. This is ideal. But short of ideal is to evaluate for the elimination of replicating HDV RNA from the liver in a surface antigen positive patient. But this particular thing require liver biopsy. So as a surrogate marker of liver tissue HDV RNA levels, one can perform a plasma HDV RNA levels. And if it is being below the limit of detection by a sensitive tool, it can be taken as a surrogate marker for the clearance of HDV from the liver tissue. At the end of the treatment, during the therapy, and 24 weeks after the treatment, there should be HDV RNA level below the detection level in order to say that this patient's HDV level is clear to a large extent. Nowadays, there is a new new definition or endpoints being considered is the quantify the HDV RNA, and then if there is more than 2 log reduction in the decline in the HDV RNA, and along with that, if there is a normalization of the ALT level, this is being the parameters, endpoint parameters, which are nowadays considered for the new ongoing clinical trials. So in short, the treatment for hepatitis delta virus is alpha interferon, investigational therapies we will discuss further, and also the liver transplant as an ultimate outcome of such patient with advanced chronic liver disease. Several interferon-related studies have been done in order to see and evaluate the efficacy and safety for the HDV infection. And in conclusion, one can say that up to 2 years of treatment shows at best clearance is 33%. And this particular HDV clearance is even lower in those who have cirrhosis. And remember that those who have advanced cirrhosis, they are at a higher risk of decompensation if they are treated with interferon. The nucleus and where there will be the replication take place in the endoplasmic reticulum. And here there is an interaction with the small HD hepatitis delta antigen and large hepatitis delta antigen. Then there is a prenylation, and after prenylation, there is an assembly of the HDV viruses. It passes through the Golgi apparatus and released into the circulation. So there are several checkpoints where one can use certain intervention and open the avenues for the new treatment for such patient. Few of the candidate drugs includes the bulevirtide, which is the entry inhibitor. Then other is the prenylation inhibitors, which is a lorafenib. Then there is interferon lambda, which is having a unique receptors that presence in abundance on the hepatocytes. So it interferes with that and affects the entry of the hepatitis delta inside the hepatocytes. So these are the few trials which have shown, as you can see here, that when the lorafenib is used along with ritonavir, the virological response rate is around 39%. But when it is being combined with lambda interferon, the virological clearance at 24 weeks time is up to 90%. So it's very encouraging results. We need a sustained virological response in the years to come, and in order to say that how much is the value of using lorafenib with ritonavir and along with interferon lambda. Likewise, the response to the biochemical response is again being around up to 70% when using a combination of lorafenib along with ritonavir and interferon lambda. These are the two new trials which are ongoing. In one trial, there is use of lorafenib, ritonavir, and PEG interferon in various combinations, and AKU is a part. Dr. Saidam is a principal investigator for the local site. And they have a 24 weeks follow-up after 48 weeks of induction with these four different groups of people. And let's see the response rate, which will come up maybe in next year. Likewise, there is another trial which is ongoing, and it is related to bulevirtide use, which is an entry inhibitor of various doses, and let's see the response to these agents as well. Government of Pakistan announces an ambitious plan in 2019 to eliminate hepatitis, and we are not sure 100% that how it will be implemented and whether they are going to achieve the ultimate goal of significant controlling hepatitis B and eradicating and elimination of hepatitis C by 2030. So we are not 100% sure, but we hope that at least significant dent can be made with the efforts at the national level in order to eliminate hepatitis from Pakistan. So in conclusion, I can say that at least 12 million individuals, if not 60, are affected, 60 million are affected from HDV. Until 2020, there is no specific treatment options available. Identification of sodium taurocholate co-transporting polypeptide and entry inhibitors for HBV and HDV allows the development of new drugs. 3 novel new anti-HDV compounds are entry inhibitors, denylation inhibitors, and nucleic acid polymers. And in combination with alpha interferon are showing encouraging results. And I conclude with the latest article, which is published in Journal of Hepatology, Changing Context of Hepatitis D, written by Mario Rosito as a principal author. And you know that Mario Rosito is the one who discovered hepatitis delta infection, delta virus. And Dr. Saidamir is a part of this. And they have concluded 2 things in this particular article, that we are at the crossroad of HDV epidemiology as it is changing due to hepatitis B vaccination and people migration. So in Europe, there are 2 different set of people who are harboring HBV and HDV. The younger individuals who are the migrant from the other underdeveloped countries, and an older individual who escaped from the HBV B vaccination in their early in their early life. The other thing is, which is at the crossroad, whether we will be able to develop some effective treatment, is the new antiviral agents, which are showing the promising results based upon better understanding of HDV life cycle, and this is promising. So thank you very much for your kind attention, and I wish for a very informative session and a very successful PSH meeting 2021. Thank you very much once again.
Thank you so much, Professor Dr. Shahab Abid. Sorry for technical reasons you are facing problems. Our next talk is on understanding EASL and SSLD guidelines and ground realities in treating HCV in Pakistan, Asia. For this talk, our speaker is very famous and eminent Professor Dr. Graham Foster. He is FRCP and PhD, holds post of Professor of Hepatology at Queen Mary University of London, and he is consultant at Bot Health in East London. He has a long-standing interest in the management of chronic viral hepatitis and runs a clinical research program studying the natural history of viral hepatitis, its impact upon patients and their communities, and novel therapies for the chronic hepatitis C. Professor Dr. Graham Foster.
Thank you very much indeed. It's always a pleasure to be invited to Pakistan, and I share the comments of our colleagues and previous speakers that it will be really nice to be able to visit Pakistan, hopefully next year. I'm hoping that I can do this live, but if not, I have a pre-recorded. My sympathies are with the AV team. These hybrid meetings are always very difficult, but if you give me control, I will share my screen If not, if you can play my pre-recording. I think the option of live presentation is not going to work out today. So could you play the pre-recording for me, please? And then I'll be delighted to take questions.
Dr. Graham, you are live with us.
Excellent.
Welcome.
Thank you very much indeed. I am hoping that you can see my screen. And I'm not hearing any complaints, so I'm hoping you'll see my screen.
Please go ahead.
So, hello to my good friends and colleagues. Let me run through the European and the American guidelines and give you my personal views on how they relate to the situation in Pakistan. These are my conflicts. And what I'm going to talk about is what's relevant in the guidelines and what isn't. Let's start with testing. And these are the American testing guidelines. They're very straightforward. They say that everyone should have one test, one-time opt-out Hep C testing. I think we would all agree with that. I think everyone in Pakistan would agree that we should test the population. And Europe has a similar approach and says that we should screen based on local epidemiology. So I think the plans that we currently have in Pakistan to test everyone for hepatitis C are exactly as recommended by European and American experts. And I don't think anyone would argue with that as a starting point. So we agree that universal testing seems appropriate. And then things get difficult because we need to think about retesting. Should we retest people every year? The expense of that would be colossal. The Americans think once a year for those at risk. Well, who's really at risk in Pakistan? Should we be retesting everyone who's ever had a medical procedure? In England and America, it's fairly easy. We have risk categorization, we stratify risk, and it's predominantly a disease of injection drug users. So that's an easy target in Europe, very similar in America, where the main risk is from injection drug use. But of course, Pakistan has a very different epidemiology. And we believe the commonest route of transmission is through needles that are contaminated, through barbers' shops, through unlicensed medical practitioners. So I think we need to think very carefully about how much money we should spend retesting people in Pakistan. And we do need some more data on who's at risk and who needs retesting, because we could waste an awful lot of money doing a lot of retesting that's not necessary. But equally, we need to retest the right people. So testing and finding people is the first part of the cascade. The second step, of course, is to assess people for treatment. And I think what we've seen in the last few years has been a major shift to keeping it simple. And the buzz phrase nowadays is MinMon, minimal monitoring. So do the least number of tests that you need to do, but do the least. And I think everyone agrees that the most important, the least that you can do is to exclude cirrhosis. And both America and Europe agree that excluding cirrhosis is critical. How to do so is not specified. I think a FibroScan is the preferred route in America and Europe, but we still use an APRI score in some of our patients who won't access hospital care very easily. And I'm sure that in Pakistan, using a simple APRI score is more than sufficient. Even a simple platelet count will pick up most people with cirrhosis. Both of the guidelines recommend that we check for drug-drug interactions. There aren't very many significant drug-drug interactions. The protease inhibitors have more problems, but for the sofosbuvir-based regimes, it's mainly the TB drugs, some of the anti-epileptic drugs that cause problems, but important to think. The Americans are concerned about pregnancy. I think that's a good suggestion. They also suggest that the blood test should be done 3 months before starting treatment. I think that's probably a counsel of perfection. I think if you have a blood test within the last 6 months that shows the patient doesn't have cirrhosis, that's fine. Even perhaps up to a year, that's okay. So I think we have to be pragmatic. 3 months is nice, but I don't think that's absolutely essential. So pre-treatment, we're all agreed that we should assess for cirrhosis. But let me just plant the seed in the minds of our colleagues about doing other things while we're there. The government hepatitis program is planning to do a large amount of screening. A lot of people who are not engaged in health services will be tested, and that provides an opportunity for doing some extra health checks. I have an enormous amount of respect for my colleagues in Egypt who have done a fantastic program to eliminate hepatitis C, and I believe they have eliminated hepatitis C. And they did a marvelous screening program going out into the countryside and testing everyone for hepatitis C. But they also used this as an opportunity to improve the health care of the population. They tested for B and for Delta when indicated. They tested for diabetes. They measured blood pressure. So there are some very simple things that can be done very cheaply once you've sent people out to test for hepatitis. And I would urge my colleagues in Pakistan to think about the bigger healthcare gains, the extra things that can be done. You really don't want to send people out, test everyone for hepatitis C, and then come back in 3 years and do the same test for hepatitis B. Let's perhaps join up a little more. Let's think like the Egyptians have, what else we can do. So pre-treatment, we've simplified things, we exclude cirrhosis, and then we go. On treatment, testing is really now becoming very limited, and the Americans say tests on treatment are not mandatory, and many of us in Europe are doing no testing on treatment. I think that's reasonable. I personally like to see my patient at least once on treatment or have one of my nursing staff see them just to reassure them, just to check that all is going well. But I think that's probably unnecessary, and many patients prefer to be followed up at the end of treatment rather than during treatment. The Americans say that we have to test for SVR12. The Europeans say don't bother. I'm afraid I'm with the Americans here. I think we do need to know the treatment has worked. We do need to be able to tell our patients they have cleared the virus. So I still perform an SVR12 check. So on-treatment monitoring is now very simple. Focus on compliance, help the patients to take their treatment, but don't worry too much about SVR12, although I still think it is useful to do. So let me move now to the treatment, and I'm going to focus on genotype 3 because clearly in Pakistan that is the major problem. And here I'm afraid we have a very different view. Here's the work of our American colleagues who say for genotype 3 without cirrhosis, you can use glecaprevir preventosvir or soft velpatasvir. There's no mention, I'm afraid, of soft DAC. For those with cirrhosis, they have the same recommendation, but they allow us to consider soft vel with perhaps voxilaprevir. That's an even more expensive treatment. So the American guidelines are really very focused on the most expensive therapeutics. The decompensated cirrhosis, they recommend for, that you can see that it's either soft lead or soft velpatasvir with ribavirin. I think a lot of us find ribavirin difficult in the decompensated cirrhotics. So we have international guidelines that recommend the most expensive medications. And interestingly, the Europeans take a rather similar tack. For treatment failure, the recommendation is soft velvox. I don't think the Americans have really thought through what happens if you've already had sofosbuvir, voxilaprevir based treatments, and they suggest an even more expensive treatment of glecaprevir preventosvir. So these are very, very high-end therapeutic recommendations. In Pakistan, with a population of many, many millions, a few dollars in the price difference It makes an enormous difference to the overall burden. And I'm afraid our European colleagues haven't been particularly helpful either, because they follow exactly the same approach that the American guidelines follow, and they recommend Sofvel or Glepib. They add an extra nuance, and they say that for the exotic subtypes, including 3B, we don't know the efficacy of Sofvel and Glepib, so they say use sofosbuvir, velpatasvir, voxilaprevir. Pakistan, of course, we believe has quite a high prevalence of genotype 3B, perhaps as much as 15%. So the recommendations are that you spend a very, very large amount of money on achieving what may be fairly modest gains. I think we have to start to be realistic. I think the European guidelines are very solid, very evidence-based, but they take no account of affordability. They take no account of cost. The American guidelines go high-end. But what I think people have not taken proper consideration of is the data from India. This is from the Punjab, just over the border, looking at SOFDAC, a large number of people, 50,000 people, and you can see the SVR rates are really very good. They're over 90%. Now, I accept that over 90%, we can do better. We could do a little better than this if we use Sofvel, if we use Glepib. Perhaps we could get 95%. Those are the sort of successes we're seeing in the UK at the moment. But we have to be realistic and say that extra 5% will require a vast increase in expenditure, and probably 92% success is probably going to be sufficient to eliminate hepatitis C from Pakistan, and that is affordable. So I think we have to be realistic, and we have to recognize that the guidelines are the guidelines of perfection, and they may not be necessary. Egypt eliminated with SOFDAC, and that's important because it tells you that it can be done with the cheaper drug combinations. So I think we need to know a little more about SOFDAC in Pakistan. We need to know if in Pakistan, perhaps with a lot of genotype 3B, perhaps with a lot of cirrhosis, will we see the 90% success that we've seen in the Indian Punjab? And that's a really important question. Do we need to think about giving people with cirrhosis something different, perhaps longer, perhaps Sofvel for those with cirrhosis? Do we need to think about picking genotype 3B and giving a slightly longer course, maybe adding ribavirin? Do we get 90% cure with genotype 3B and cirrhosis in Pakistan? And how much money do you have to spend on retesting? If patients have an SVR 12, do you need to check them again a year later? These, for me, are the critical questions for Pakistan. They're not the questions for Europe or America, where they have a different set of problems. But in a country where we're using mainly SOFDAC with 90%, perhaps 95% efficacy, perhaps with some problematic genotypes, we have a different question. So I'm pleased to say that we've joined forces. The Wellcome Trust have funded a very large study with my good friends and colleagues, Saeed Hamid, Saad Niaz, Huma Qureshi, and Asad Chowdhury. And over the next 3 or 4 years, we'll be trying to answer some of these questions in Pakistan, looking at how effective SOFDAC is, looking at the differences in the genotypes, and there'll be some retreatment trials to try and answer the question of what to do in those who fail. So I hope that over the next few years, we'll be able to give some proper answers to the questions that are important to you in Pakistan, rather than the questions that are important to the Americans and the Europeans. So in summary, Mr. Chairman, ladies and gentlemen, the recommendations are helpful. The recommendations on testing and minimal monitoring, I think, are applicable to Pakistan. I think the treatment guidelines are simply not appropriate. I think what you're doing with SOFDAC is working very well, and I would strongly encourage you to continue with an affordable elimination campaign rather than follow European and American perfectionist approaches. And I think for me, the most important message is to develop evidence-based local guidelines that are relevant for the people of Pakistan, because that's how we will get the best value and we will achieve the most. And on that, Mr. Chairman, thank you for your invitation. Thank you for listening, and I look forward to taking any questions.
Thank you so much, Dr. Graham Foster. We would like to take questions at the end of this session. If you feel easy, kindly stay with us. Our next talk is again on hepatitis B, treating hepatitis B in special population. From Dr. Maria Buti, she is Professor of Medicine and Chief of Internal Medicine and Hepatology at Hospital General Universitari Vall d'Hebron, Barcelona. She has published more than 300 papers in field of liver disease and has a lot of contribution to multiple books. She is the Vice President of the Spanish Association for the Study of Liver Disease, and she is an active member of EASL, NT-SSLD, and various professional societies. Professor Dr. Maria Buti.
Good morning. Many thanks for the invitation. It's also for me a pleasure to participate in this meeting, and I agree with the previous speakers that it's really pity don't have a face-to-face meeting and enjoy the opportunity to meet all together. I have also a pre-recording presentation. Please, if you can go ahead to the pre-recording presentation.
Hello, everybody.
Your
My
recorded
name is Maria
presentation is
Buti. I am Professor of Medicine at Hospital Universitari Vall d'Hebron de Barcelona. And my task today is to talk about treating hepatitis B in special populations. First of all, I would like to thank the organizers for inviting me to talk about this important topic that I would like to focus in three special situations: hepatitis B in pregnancy, hepatitis B during immunosuppression, and hepatitis B and hepatitis C co-infection. And I would like to discuss these three special situations throughout clinical cases. Let's start with the first clinical case in relation to pregnancy and hepatitis B infection. This is a 90-year-old woman born in China, referred for detection of HBs antigen at screening of pregnancy. Her blood test shows completely normal ALT levels, HBe antigen positive, and high levels of HBV DNA. The first thing in a case of suspected HBV infection, that is HBs antigen positive, is to differentiate between chronic HBV infection and chronic hepatitis B. And following the EASL algorithm for the management of hepatitis B infection, this is really important because if the patient has a chronic hepatitis B with or without liver cirrhosis, there is indication to start treatment. If the patient has chronic HBV infection without signs of chronic hepatitis, the situation is completely different. Then we have to monitor HBV infection that includes HBs antigen determination, HBe antigen, HBV DNA, and ALT levels and fibrosis assessment. In this situation, if there is no signs of chronic hepatitis, the recommendation is to monitor and consider special situations, that is the risk of HCC, the risk of HBV reactivation, extrahepatic manifestations, and the risk of transmission. Here, in our clinical case, this woman has no signs of chronic hepatitis. Probably he has a chronic HBV infection, and in this situation, it's important to consider the risk of HBV transmission. Looking at different phases of chronic infection in a patient HBe antigen positive, the two potential situations are chronic infection and chronic hepatitis, and in this case with high levels of HBe antigen, HBV DNA, and normal ALT levels, usually these patients don't have liver disease or minimal liver damage, and the diagnosis is chronic infection. These women during pregnancy, particularly at the time of delivering and during the perinatal situation, there is an increased risk of transmission of HBV based on maternal viral load. And here in this study, we can see that the risk of transmission increased with high maternal viral load, more than 10 to the 6, 10 to the 7. In this situation, the possibility of infection of the newborn is between 10 to 30%. So in our patient with HBV DNA levels higher than 10 to the 6, clearly exists a risk of hepatitis B transmission to the newborn. The best way to prevent the transmission of HBV from the mother to child is with antiviral therapy. And this study, a randomized study performing mothers with high viral load, more than 200,000 international units. In this study, these women were randomized to receive TDF in the last trimester of pregnancy or no treatment. And we can see that the rate of infection, of newborn infection in the group under TDF was 0, while those in the control group was 7%, showing that TDF clearly prevents transmission of hepatitis B in addition to hepatitis B vaccination and immune globulin. Here we have the EASL hepatitis B recommendations in case of pregnancy, and the recommendation is screening for HBs antigen in the first trimester of pregnancy is strongly recommended, evidence level 1, grade of recommendation 1. A pregnant woman with chronic hepatitis B and advanced fibrosis or cirrhosis, therapy with TDF is recommended. Again, an evidence level 2, grade of recommendation strong. And in all pregnant women with high HBV DNA levels, that means more than 200,000 international units per ml, or HBs antigen levels more than 4 logs, antiviral prophylaxis with TDF should start at week 24-28 of gestation and continue for up to 12 weeks after delivery, and this is a high level of evidence and recommendation. So going back to our clinical case, this pregnant woman with HB antigen positive, normal ALT levels and high levels of HBV DNA in an immune tolerant situation, the recommendation and the management is non-antiviral therapy during the first trimester, because she doesn't have any data of liver disease. And during the third trimester of pregnancy, start treatment with TDF. We started treatment, and at the time of delivery, HBV DNA dropped to 320, and then we vaccinate the newborn and give immune globulin And the outcome was at year 1, this newborn has HBs antigen negative. So clearly we prevent hepatitis B transmission from the mother. Let's go to the second clinical case. It's a case in relation to immunosuppression and HBV infection. This is a more and more frequent situation. We have a large number of drugs, immunosuppressive drugs, and we use more and more. And this is a 64-year-old man diagnosed with non-Hodgkin lymphoma and candidate to receive chemotherapy plus rituximab. So in this situation, and this is a recommendation, it's important screening of infection in patients undergoing immunosuppressive therapy. The recommendation is screening for hepatitis B with HBs antigen and anti-HBC, and if one of those are positive, HBV DNA, hepatitis C with anti-HCV antibodies, and also screening of tuberculosis, HIV, and syphilis. So all patients before are receiving immunosuppression need to be tested for these viruses or these infections. And the situation in our patient is that all tests were negative except anti-HBC, that is positive, anti-HBC alone with HBs antigen negative. Then we test for HBV DNA, and HBV DNA was undetectable. So we have a patient with a lymphoma non-Hodgkin that is going to start rituximab, anti-HBC positive, please, undetectable HBV DNA. And the questions that we need to answer are, is this patient at risk of HBV reactivation? Is the antiviral prophylaxis recommended? How often should HBV infection be monitored during immunosuppression? And any other marker that might be useful. So the risk of HBV reactivation depends on the liver disease, depends on the baseline disease, the level of immunosuppression, and HBV status. In relation to disease, bone marrow transplantation or solid organ transplantations or HIV co-infection are the situations with the higher risk of reactivation. In relation to the drugs, here you have different drugs and the risk of reactivation, such as light traffic. In red, the drugs with a higher risk of reactivation, rituximab. In orange, those with intermediate risk, particularly if they are combined with prednisone, and finally drugs with low or null risk of reactivation. And in relation to the virus, the risk of reactivation is much higher in those HBs antigen positive patients, followed by those anti-HBC positive patients. But there is a special situation that is our clinical case, that is patients under rituximab, both HBs antigen positive and also those HBs antigen negative but anti-HBC positive have risk of HBV reactivation. Prevent hepatitis B reactivation, it's important because when we started immune suppression, if patients have HBs antigen positive and low levels of HBV DNA, at the time of starting immunosuppression, there is an increase in HBV DNA levels. This increase and this can be silent, can be like an acute hepatitis, an acute self-limited acute hepatitis B, or even some patients can develop chronic hepatitis or hepatic failure and death. So it's very important to prevent HBV reactivation. So what is the recommendations? The EASL recommendations for patients undergoing immunosuppressive therapy or chemotherapy. All candidates for chemotherapy and immunosuppressive therapy should be tested for HBV markers prior to immunosuppression. And this is a high level of evidence and grade of recommendation 1. All HBs antigen positive patients should receive entecavir or TDF or TAF as treatment or prophylaxis, and it's also a strong grade of recommendation. And finally, like in our patient, HBs antigen negative, anti-HBC positive subjects should receive anti-HBV prophylaxis if they are at high risk of reactivation, particularly if they are receiving treatment with rituximab, because the risk of reactivation is relatively high. So in our patient, we started treatment with rituximab. The patient has a good response to rituximab. Prophylaxis with TDF was initiated before starting rituximab. He was monitored with HBV DNA and ALT levels, and there is no signs of HBV reactivation 2 years after the starting rituximab, showing that we can prevent HBV reactivation using antiviral prophylaxis. We have done a randomized study evaluating TDF versus placebo for preventing HBV reactivation in this subset of patients, anti-HBC positive patients under treatment with rituximab. A total of 61 patients were enrolled in this study, and as the guidelines recommend, HBV reactivation was absent in the TDF group, in those receiving tenofovir, and in the control group, in the observation group, 10% of patients show HBV reactivation. So in those patients that are going to receive rituximab plus chemotherapy, even being anticore positive alone, prophylaxis is recommended. Finally, the last situation I would like to comment is hepatitis C and hepatitis B co-infection. And the clinical case is a 41-year-old male born in Punjab, recently moved to Barcelona, and he was diagnosed with hepatitis C, elevated ALT levels, HCV-RNA positive, and infected by genotype 3. He got a normal liver ultrasound, and the fibroscan shows a 7.5 kilopascals. That means moderate fibrosis. So now the question is, should any other serological test be performed before starting antiviral therapy for hepatitis C? And the recommendations, the EASL recommendations are all patients should be tested for other hepatotropic viruses, particularly hepatitis B, and for human immune deficiency HIV. And the ASLD recommendation is similar, evaluation for other conditions that might accelerate the liver fibrosis, including HBV and HIV infection, is recommended for all persons with hepatitis C infection. So the recommendation is screening HIV with antibodies and screening of hepatitis B with the determination of HBs antigen, anti-HBC, and anti-HBs. And also, in case of HBs antigen positive, exclude delta hepatitis. So we perform a HIV screening. Anti-HIV antibodies were negative, and HBV screening. HBs antigen was positive, anti-HBe positive, low levels of HBV DNA below 2,000, and anti-hepatitis D antibodies are negative. So it seems that this patient has an active hepatitis C, and it's like a chronic hepatitis B carrier. But you know that there is an influence between viruses, and sometimes hepatitis C can suppress hepatitis B. So the final diagnosis was hepatitis C and hepatitis B co-infection, genotype 3, naive, with moderate fibrosis, and we decided to start treatment with sofosbuvir velpatasvir for 12 weeks. And now the question, is this patient at risk of HBV reactivation during hepatitis C therapy, taking into account that with hepatitis C treatment, their HCV RNA will become negative, and there are actions of increase the levels of HBV DNA, and in which cases should antiviral prophylaxis for hepatitis B be recommended? So the available information is limited, but this study performed in Taiwan in a large number of co-infected patients, 111 HBV, HCV co-infection. These patients, the majority of them HBe antigen negative, 33 with undetectable HBV DNA, started treatment with lenacapavir, sofosbuvir, and were followed during treatment and after treatment. Overall, 30 patients, 28% have an increase in the HBV DNA levels, plus an increase in but without increase in ALT levels. No patient has adverse events such as jaundice, liver decompensation, liver failure, or require a liver transplantation. And in the course of the treatment, HBV DNA increased in 63% of patients, and 2 patients started hepatitis B therapy. So what are the recommendations for management of hepatitis C co-infected patients? So treatment of hepatitis C with direct antivirals may cause reactivation of hepatitis B. Patients fulfilling the standard criteria for hepatitis B treatment should receive nucleoside analogues treatment. HBs antigen positive patients undergoing DDA therapy should be considered for concomitant nucleoside analog prophylaxis until week 12 post DDA and monitored closely. And those HBs antigen negative, anti-HBC positive patients undergoing hepatitis C treatment should be monitored and tested for hepatitis B recommendation in case of ALT elevation. In our patient, because HBV DNA levels were low, antiviral prophylaxis was not initiated. The patient during treatment with sofosbuvir velpatasvir has an important drop in ALT levels and HBV DNA levels remains more or less stable, and when treatment was stopped, was discontinued, ALT were completely normal, and there is a slightly transient increase in HBV DNA levels. We decided, after sustained virological response, to perform a liver biopsy to better assess hepatitis B infection. And we found fibrosis, mild fibrosis, and mild neuroinflammation. And because the patient has normal ALT levels and low levels of HBV DNA, we decided to monitor this patient every 6 months, and initially consider this patient like an inactive hepatitis B carrier. So, in summary, chronic hepatitis B and special situations, screening for hepatitis B infection in pregnancy before immunosuppression and in HCV infection is strongly recommended for all international guidelines. All HBs antigen positive cases should be tested for HBV DNA and assessed for hepatitis B prophylaxis. And finally, nucleotide analogues are the recommended prophylaxis. Again, many thanks for the invitation.
Thank you so much, Dr. Maria Buti, for a nice talk on the management of hepatitis B in a special population. If there are any questions, two speakers, Professor Maria Buti and Professor Dr. Shahab Abid, are with us. One question is, what are chances that we are going to shift from hepatitis DNA level directed treatment protocols to surface antigen level protocols? What are chances that we are going to shift from HBV DNA level directed treatment protocols to surface antigen level protocols? Professor Maria Buti, can you hear us?
Yes, I can hear you, but please, could you repeat the question?
So what are chances that we are going to shift from HBV DNA level directed treatment protocols to surface antigen level protocols?
Yeah, I think for the new drugs under development, it's important evaluation of HBs antigen levels, because we are going with these new drugs to look for functional cure. With the current drugs, HBV DNA levels is the classical marker to evaluate response. If in addition to undetectable HBV DNA, there is a drop in HBs antigen levels, then the patient has a higher likelihood of achieving HBs antigen loss.
Thank you. Professor Dr. Shahab Abid, can you hear us? Are you there?
Yes, I can hear you. No problem.
One question is that one consultant monitored HBV levels every 3 months on interferon treatment, and if it shows declining viral loads but still positive at 48 weeks, he extend treatment to 72 to 96 weeks until negative. Do you agree with this management plan, Dr. Shahab Abid?
Thank you for asking this question. This is a tricky situation, as we know that the only treatment available for hepatitis delta virus is basically related to off-label use of alpha interferon at the moment. Experimental setting, that is the only viable treatment, and one of the endpoint would be either the clearance of HDV level below the detectable level, or if there's a -2 log reduction with normalization of the liver enzymes. So it depends upon the endpoint which we are following. If we are following a -2 log reduction and normalization of ALT, then maybe 48 weeks is fine. So less than 48 weeks has no justification, but beyond 48 weeks, the data is not very much to support that we should continue beyond 48 weeks. But if there's a 2 log reduction achieved with normalization of ALT, one can stop. And if there is no 2 log reduction and 48 weeks have gone, I don't think that continuation of further treatment may be of any benefit. At least it is not supported by studies. Having said that, anecdotally, you can try on individual basis, but data is not supporting this.
Thank you so much. Another question is from Dr. Mayabhuti, and this may be the last question because we are short of time. Professor Dr. Mayabhuti, can we use quantitative surface antigen to differentiate hepatitis B antigen negative chronic hepatitis B from E antigen negative infection inactive carrier in order to decide start of treatment? Professor Dr. Mayabhuti.
Yes, we can use HBs antigen levels, particularly for patients infected for genotype B. There is a study performed in Italy that shows that inactive carriers, HBs antigen levels below 100, it's very, very suggestive of inactive carrier. But in other genotypes, this correlation is not so strong. So if you live in a country like Italy, that the majority of your patients are infected by genotype B, you can use. But if in your country you have different genotypes, particularly genotype E and genotype F, that are genotypes from sub-Saharan Africa, then the level of HBs antigen to differentiate between inactive carrier and patient with chronic hepatitis it's not very well known, and my recommendation is in countries with predominant genotype E and F, don't use HBs antigen levels.
Thank you so much. Juma prayer time is 13:30 across the road opposite the hotel, and our next session will be exactly on 14:15 after lunch and Juma prayer. So kindly be on time. We are highly thankful to Professor Dr. Shahab Abed and Professor Dr. Mayabhuti. They remained with us. And at the end, I would like to concluding remarks from our teacher, from our chairperson of this session, Professor Dr. Badr Fiyaz Zubairi Sahab.
Well, it was a very exhaustive and very detailed session about hepatitis B and D, and we have seen a very good and excellent presentation from our speakers, both internationally. And we had a very good session for hepatitis C from Graham Foster. Graham Foster has been around in Pakistan many times, and other presenters were also very good. So I hope that you all have enjoyed. These presentations have gained a lot, and I foresee the very next exciting sessions coming up on the next program like this. So have prayers and lunch and come back on time. Thank you so much.
Thank you so much.
Thanks a lot for the invitation.
Thank you, Dr. Altaf Alam, and thank you, Brother Fayaz Zubairi, for conducting this session and for a very kind invitation. Thank you.